In this video, we shall be discussing a few important concepts regarding your abdominal trauma. So let's begin our discussion with the discussion on FAST. So FAST stands for your focus abdominal sonography for trauma. This itself is a one-liner MCQ that has been asked. Now it is used to assess torso in presence of free fluid in the abdomen. Now there is a variant of FAST which is your E-FAST when it is extended into your thoracic cavity. So you have this image which has been taken from the net showing your trauma FAST examination, where you have your first subxiphoid window, then you have your hepatorenal, splenorenal and your suprapubic views. Now in case of your E-FAST, you can see over here that your right anterior and your left anterior chest views are added. So this is with respect to your FAST and E-FAST. Now the important points with respect to FAST and E-FAST are: it does not reliably detect less than 100 ml of free blood, it does not directly identify the injury to the hollow viscus, it cannot reliably exclude the penetrating injury, and it is unreliable for assessment for the retroperitoneum. Right. Now another imaging modality important in your abdominal trauma is your diagnostic peritoneal lavage. Now this is not used in modern day great setups, it is only used in your resource limited settings. Now it assesses the presence of blood or the contaminants in the bowel. A nasogastric tube is placed in empty stomach and urinary catheter is inserted to drain the bladder. Now when do you say it to be a positive diagnostic peritoneal lavage? When you have more than 1 lakh red cells, more than 500 white cells, presence of amylase, presence of bile and presence of frank blood in your diagnostic peritoneal lavage. Right. Now the current modality investigation of choice in a hemodynamically stable patient is your contrast enhanced computerized tomography scan. So we have this table taken from your ATLS 10th edition which compares your diagnostic peritoneal lavage, FAST and CT in abdominal trauma. So let's look at the advantages of your diagnostic peritoneal lavage. Early operative determination, perform rapidly, can detect bowel injury and no need for transport from your resuscitation area. Your FAST, it is again an early operative determination, it is non-invasive, perform rapidly, repeatable, no need for transport from resuscitation area. Now in CT scan, the advantages include your anatomic diagnosis, non-invasive, repeatable, visualizes retroperitoneal structures as well, it visualizes bony and soft tissue injury and the extraluminal air. Now looking at the disadvantages, we have your invasive, risk of procedure related injury, requires gastric and urinary decompression for your prevention of complications, not repeatable, interferes with the interpretation of your subsequent CT or FAST, low specificity and can miss diaphragm injuries. Now your E-FAST is your operator dependent, bowel gas and subcutaneous air can distort images, can miss your diaphragm, bowel and pancreatic injuries, does not completely assess your retroperitoneal structures, do not visualize the extraluminal air, and body habitus can limit your image quality. Now the disadvantages of your CT scan include your higher cost, radiation and IV contrast exposure, can miss diaphragm injuries, can miss some bowel and pancreatic injuries, and it requires your transport from resuscitation area. Now taking a look at the indication, abdominal hemodynamics in your blunt abdominal trauma and penetrating abdominal trauma without other indications for your immediate laparotomy. E-FAST, and you have abnormal hemodynamics in a blunt abdominal trauma and penetrating abdominal trauma without other indications for your immediate laparotomy. So over here you need to remember that CT scan is done in your normal hemodynamics, right, be it a blunt trauma or your penetrating trauma, and in case of a penetrating back or a flank trauma without other indications for your immediate laparotomy. So this is your table for your DPL, CT scan and your FAST, which is a comparative analysis. But as a general rule, do remember that in a hemodynamically stable patients, in case of your abdominal trauma, these days we do a CT scan. Now let's take a look at a generalized approach of your blunt abdominal trauma. Now this generalized approach can be applicable for each and every organ that we move ahead. So if there's a blunt abdominal trauma, we do an abdominal examination including your FAST. Now we check for the peritonitis. Now if there is a peritonitis features, then what we do is your exploratory laparotomy. Now, if there is no features of peritonitis, then we do an abdominal CT scan, right? Now, in abdominal CT scan, we check for your hollow viscous injury. Now, if there is an hollow viscous injury, then we would go for an exploratory laparotomy. Now, if there is no hollow viscous injury, then we move towards the next part to check for a solid organ injury. Now, if there is a solid organ injury, then we check if it is grade 4 or grade 5. Usually in grade 4 or grade 5, you would require a laparotomy, whereas grade 1, 2, 3 can be undergoing non-operative management. Now, similarly, if you find that there is no solid organ injury, we check for your free intra-abdominal fluid. Now, if there is no free intra-abdominal fluid, then we can go for your conservative treatment. Now, if there is free intra-abdominal fluid, then we would check for whether there is a large amount of fluid, a seat belt sign, if there is any abdominal tenderness or abnormal vitals, right? If the answer to these questions is yes, then we go for a laparotomy, whereas if no, then we go for your serial examinations and observations. Now, similarly, in case of a penetrating trauma, so this is your blunt trauma flow chart, right? So, if we just follow this flow chart and keep it in mind, we will be able to solve most of our trauma questions, and this would even help us in our real life scenarios. Now, coming down to the next part, which is your penetrating trauma. So, if there is a penetrating trauma and you see that the patient is in shock, peritonitis or evisceration, then you would definitely proceed for a laparotomy. Now, if the answer is no, and then you do a local wound exploration. Now, if the local wound exploration is negative, you plan a discharge for the patient, right? Now, whereas if positive, then you would admit for observation. Now, if there is any instability, then you would take the patient for a laparotomy. If there is no instability, then we check for any significant decrease in hemoglobin and presence of leukocytosis. If the answer is yes, then you would need to go for an exploratory laparotomy or need a CT scan prior to going for your exploratory laparotomy. And if there is no decrease in hemoglobin or increase in count, then we can initiate the and plan the patient for discharge. Right. So, these are your concepts with respect to your penetrating trauma. Now, moving down to some important key points with respect to your solid organ injury, specifically your liver and spleen. So, first, liver penetrating injury is much more common in liver compared to your blunt. Now, there are 4 P's used in the management of liver trauma, which is a pressure, Pringle, plug, pack. Right. Now, regarding your Pringle maneuver. So, what is your Pringle maneuver? This is the control of inflow from the portal triad. So, as a result of which what happens is that the arterial and portal flow into the liver is reduced, but it does not control the backflow from the IVC and your hepatic veins. Right. So, these are your few important points with respect to your liver trauma. Please remember the 4 P's and remember that push is not the part which is a most commonly question asked in your liver trauma. Then the management would include the same blunt trauma algorithm that we had applied over there. And now, regarding your classification, I have taken this image from the net source. So, you have your grade 1, which is your less than 1 centimeter depth and less than 10% surface area. Then you have grade 2, which has a laceration of 1 to 3 centimeter in depth and an intraparenchymal hematoma less than 10 centimeter of diameter and a subcapsular hematoma of your 10 to 50% surface area. Your grade 3 would be a more than 3 centimeter laceration, more than 10 centimeter intraparenchymal hematoma and more than 50% of surface area. Right. Then you have your grade 4, which is usually your 25 to 75% of hepatic lobe disruption, and you have your grade 5, which is more than 75% of your lobe disruption. So, please remember this grading for your liver trauma. Now, then we have your spleen trauma. So, even for the splenic trauma, we need to remember the grading. So, it would be a 1 centimeter depth, less than 1 centimeter depth, less than 10% surface area, which will be your grade 1, then 1 to 3 centimeter depth and less than 5 centimeter, of your intraparenchymal hematoma and 10 to 50% surface area at grade 2. Then you have your grade 3, which is your more than 3 centimeter depth, more than 5 centimeter diameter, and more than 50% surface area. You have your grade 4, which is your vascular injury and your intraparenchymal hematoma. Vascular injury is around 25 to 75% of devascularization, and in your grade 5 you have your shattered spleen, right. Now, the algorithm for your splenic trauma would essentially be the same. So, if you have a suspected splenic trauma in initial evaluation in an unstable or peritonitis patient, you go for a laparotomy. Now, if it is hemodynamically stable, your choice would be a CT scan. Now, in a grade 1 and 2, you can do a serial hemoglobin and your abdominal examination. In grade 3 to 5, you can consider embolization, also in presence of a blush and a moderate to large hemoperitoneum. Now, if the patient still bleeds at 24 hours, then we go for your laparotomy and splenectomy, right. So, this particular algorithm can be used for your splenic trauma, but essentially the concept remains the same as we had discussed for your blunt abdominal trauma. Now, this is with respect to your kidney grading. So, we have over here grade 1, which has no laceration and a subcapsular hematoma or a contusion. Then in grade 2, we have a laceration less than 1 centimeter depth and a peritoneal hematoma confined to your perinephric fascia. Then in your grade 3, we have your laceration more than 1 centimeter depth and vascular injury or active hemorrhage confined to your perinephric fascia. Then your grade 4, we have your laceration with pelvic involvement or the uteropelvic disruption. Then we have active bleed, which is extending beyond your perinephric fascia, right. And in your grade 5, we have a shattered kidney, a devascularized kidney with an active bleeding, or any main artery or vein laceration or hilar avulsion. So, for this kidney traumas also, we would be essentially following the same algorithm of the blunt trauma that we had discussed. Now, this last concept we would discuss over here in your abdominal trauma is your retroperitoneal hemorrhage. So, it is divided into your 3 zones. So, you have your zone 1, which includes your major vessel. So, any injury over here, it would require an exploration, right, because it involves your major vessel. Then you have your zone 2. Now, zone 2 is involving your kidney, right. So, over here you would basically do a conservative treatment. Now, it would need a surgery when you have your expanding hematoma. So, expanding hematoma is one of the conditions where you would have to do an exploratory laparotomy in case of a zone 2 injury. Now, zone 3 injury includes your pelvic vessels injury. So, you will need to do a conservative management, right, in this case 2. So, please remember with respect to your retroperitoneal hemorrhage, basically when you have your zone 1, which includes the aorta and IVC, you would need to do an exploration. In case of a zone 2, you would basically do an conservative treatment, surgery when it is an expanding hematoma, or you have your continued blood loss. And your zone 3 is basically due to your pelvic vasculature, and it would generally consist of your conservative treatment. So, this were the important points with respect to your abdominal trauma.